Hello, everyone. I'm happy to introduce today's two presenters. We have Dr. Eric Ramos, who is a highly motivated healthcare executive with comprehensive knowledge and experience leading healthcare teams. Dr. Ramos served as Chief Medical Officer at Memorial Medical Center in Modesto, California, and the Northern California Group for Tenet Healthcare. Additionally, having previously served as CMO and Medical Director for Doctors Medical Center, he served as CMO of Long Beach Medical Center in LA County and CMO of HCA's Far West Division, where he led clinical excellence programs at division hospitals. Clearly, a lot coming from the C-suite you will hear today. Dr. Ramos's career in healthcare leadership involved helping hospitals optimize the quality of care through rigorous outcome measurements and performance improvement processes. He firmly believes that high-level goals are achieved through team building, strategic planning, improving operational efficiencies, and frontline accountability. Chris Lee is our infectious disease epidemiologist who obtained his master's in public health with a specialization in epidemiology from The Ohio State University back in 2020. Since then, Chris has operated as an independent consultant within the biodefense and healthcare sectors, helping his clients design and implement studies pertaining to microbial risk assessment. Chris obtained his master's in business administration from Indiana University in 2023, further igniting his passion for helping his clients jointly pursue their technical and corporate goals. Thanks to our two co-presenters, I will hand over the webinar now to Dr. Ramos. Dr. Ramos.
Thank you, Denise, and welcome everybody to today's presentation. It's an honor to be teamed up with Chris Lee to present as a co-presenter. I want to start off by looking at this joint statement that APIC and the Leapfrog Group have put out. And it's interesting, I scratch my head at the end of a pandemic that people are even thinking about reducing the IPC environment. It's I think looking at the infection prevention as a cost center is short-sighted, and certainly people don't understand what IPC brings to the table. In my 15-year career as a CMO, I think there's no more important departments than the IPC and EVS if we're really truly going to prevent infections. I'm going to start talking a little bit about how to build a business case for you guys so that you can go to your C-suite and see if you can get more funding for your department. And we'll kind of go through some slides and kind of talk about how to do that. Let's move on to the next slide. So as you know, value-based purchasing programs have been instituted, and this was CMS's way of making sure that we have quality of healthcare delivered, not just healthcare. And so they started looking at complications, mortalities, infection rates, and realized that they had to change the way they were doing things. So the value-based purchasing programs were developed. And they have three aims. One is to improve better healthcare for the individual, also improve healthcare for the population, and lower costs. So as we move on to the next slide, I'm going to kind of delve into the different domains that VBP awards hospitals for. And those areas are safety, clinical care, efficiency and cost reduction, and care coordination, patient and caregiver-centered experience of care. And for our discussion today, really want to focus mainly on safety. So these safety measures that you're looking at are your usual suspects. The CLABSIs, CODIs, SSIs, C. diff, and sepsis. But as well as that, I think you also need to be aware of the efficiency and cost reduction that your department adds to the mix. Every diagnosis or diagnosis-related group, you get a certain amount of money and a certain amount of length of stay that Medicare will pay. Above and beyond that, the patient, the hospital eats that bill. So imagine if a patient gets a CLABSI and has to spend 3 or 4 more days in the hospital, or even worse, spending time in the ICU. All of that money is lost revenue for the facility. And the bottom one is as well, think about a patient who gets eclampsia or CODI, and think about their patient experience. How well do you think they're going to mark your facility if they get one of these HAIs or hacks? Let's go on to the next slide. I want to talk a little, well, first on the left side are all of the measures that are in the safety domain. So again, you guys are all familiar with all of these CODIs, CLABSIs, CDI, MRSA, SSI, and sepsis. And I'm going to pause here for a second because I want to kind of talk a little bit about the importance of your department and how you team up with other people. If you look at preventing CODIs, really those are like nurse-driven things now. Most facilities have nurse-driven protocols to remove Foley catheters, but it really behooves you to be working with your nurse leaders to make sure that the nurses are following those guidelines. CLABSIs, again, this is a team effort. Where is the central line? Is it in the femoral vein? Is it in the IJ, or is it in the subclavian? We know by evidence that subclavian is a much safer place and less likely to get infected. But these are, I just wanted to illustrate that because it really does talk about the teams you have to build in order to prevent each one of these infections. C. diff, antimicrobial stewardship, and EVS are your partners. MRSA, those are probably standard screening protocols that you guys are doing. SSI colon and SSI abdominal hysterectomies, looking at how are the surgeons irrigating a contaminated wound intra-abdominally. So I just wanted to focus on that for a second, but also then moving over to the right side of the slide, look at how your value-based purchasing money is given back to you. You are scored by two levels. One is achieving points. So are you improving? Are you moving the needle and decreasing your hacks and HAIs? And then the other one is for improvement points. How well did you improve? Now, if you're a late adopter to this, to moving the needle on these, you'll find that the benchmark has continually to get harder to achieve. That's because most other facilities and most other hospital organizations are already well underway of dealing with these issues. Let's move on to the next slide. So on the flip side of the coin, CMS not only incentivizes facilities to provide optimal care, but it also penalizes them for substandard care, specifically in hospital-acquired conditions. These programs penalize based on poor performance on safety infection measures, and these penalties, as you'll see on the next slide, can be quite large. So this is data from a fiscal year 2021 that found that more than 773 U.S. hospitals faced hack penalties for a total of $254 million in lost revenue. Listed on the slide are the top 5. And look at those numbers on the estimated revenue loss, anywhere from close to $2 million to $4 million. And there is not a facility in the United States or in the world that can afford to leave this type of money on the table. So I bring this up because I want you to understand and make sure that you have this data in front of you when you're talking with your C-suites. What was your hack penalty? What was your value-based purchasing incentive that was given back to you, or how much money is left on the table? So that is the money you can start going after with discussions with the C-suite. On the next slide, so CMS has also looked at not only quality and outcomes, but also looking at the patient's experience. What is their experience in the hospital? And so each one of these domains is equally weighted. And you can see cleanliness and quietness of the hospital environment is one of the top domains. So they want to know that the patient feels like the hospital cares about cleanliness, that the room was clean, that they saw people coming in and cleaning the restrooms. In fact, many hospital organizations have adopted a postcard or a little card a tent card that they leave on the patient's bedside table or over bed table, so that it's stating that we cleaned your room, you were sleeping, but we did a thorough cleaning of the environment. And that's a way to increase the responses, the positive responses on cleanliness and quietness environment. But cleanliness is not always what it seems. So go on to the next slide. This is a multi study from that we used, and they actually looked at different environments, and they did data cleaning and terminal cleaning, and you can see 110,000 surfaces were cleaned, and they found out through fluorescence that only 32% or average of 32% were clean. So there's a lot of room to improvement, and there is a lot of opportunities for us to go after. I do want to make sure that you understand that if you need any help in dialoguing or looking at your numbers, I would be more than happy to help you in how to set that up, working with our Synexis team. I want to turn it over now to Chris, because as you can see, even though we think things are clean, they're not. And dry hydrogen peroxide is a great technology. And I'm going to turn it over to Chris Lee now, and he can talk a little bit about the technology and the science behind it, as well as the evidence that we have created. Chris?
Thank you very much, Dr. Ramos, for sharing your insights and for highlighting the challenges faced by both EVS and infection preventionists in these dynamic healthcare environments. As Denise mentioned earlier, my name is Chris Lee, and I've had the pleasure of working with Synexis dry hydrogen peroxide technology for about the past 6 years, during which time I've been blessed with the opportunity to observe and investigate the impacts of DHP within a wide variety of healthcare facilities from the perspective of epidemiology. Today, I'm going to discuss exactly what DHP is, how it's produced, as well as the intended application of the technology, specifically how DHP can provide a passive element of continuous microbial reduction within your occupied spaces that is designed to work in tandem with your current manual and terminal cleaning practices without adding the need for additional staff to deploy the technology. So as Dr. Ramos emphasized earlier, environmental contamination of air and surfaces poses a very serious problem within healthcare, often outpacing the capacity of understaffed EVS teams who really need to wait until the spaces are vacated to conduct manual and sometimes their terminal cleaning. And this leads to dynamic swings in the healthcare or in environmental contamination within these facilities. So depicted in the top left of the slide, where you see the microbial load dropping down to clean levels after your manual and terminal cleaning, only for it to then spike again as soon as the space is reoccupied, either by patients or staff or visitors or what have you. So Synexis dry hydrogen peroxide is designed to work in the background, operating continuously in these occupied environments in between deployments of your intermittent cleaning practices. DHP provides a source of consistent environmental stress in these occupied spaces that immediately contacts pathogens upon their introduction to the environment, with the ultimate goal of achieving a steady state reduction, as you can see in the bottom left, in microbial load that can then be maintained over long periods of time. So this next slide is going to provide a brief animation of how DHP is produced and how it maintains an equilibrium concentration within the deployed space. So as you can see, ambient humidity and oxygen pass into the device, where a photocatalytic reaction then occurs, reorienting the molecules into low concentrations of the true gas phase of hydrogen peroxide, termed dry hydrogen peroxide, or DHP. The DHP disseminates throughout the entire deployed area, where it achieves and maintains a consistent equilibrium concentration. When DHP comes into contact with a microbe in the air or on a surface, the DHP molecules then disrupt the microbe's vulnerable external structures, thereby weakening it until it ultimately bursts under its own hydrostatic pressure. As previously mentioned, the concentrations of dry hydrogen peroxide that are emitted by the device and are maintained within the space are safe for continuous operation within occupied environments. This then allows DHP to act as a point of risk countermeasure to bacteria, viruses, yeast and mold, as well as volatile organic compounds that might be introduced into your dynamic healthcare environment. To further illustrate on the next slide the breadth of organisms DHP can impact, this slide lists many of the pathogens which DHP has demonstrated efficacy against within lab environments, both in the air and on surfaces. And as you can see, and this is a small selection of the overall data that we've seen, but this includes both gram-positive bacteria such as C. diff, Listeria, MRSA, as well as gram-negative bacteria like E. coli, Pseudomonas, Klebsiella, and then as well as both types of viruses, enveloped and non-enveloped, and then even the Mycobacterium surrogate that's typically used for tuberculosis. And so on this next slide, we're going to really illustrate what these devices actually look like. On the left is the original design of the DHP device called the Blade, which was meant to be installed within the HVAC duct at the diffuser level. While this solution is no longer as popular within healthcare, it is really still a versatile solution for sensitive population areas such as neurobehavioral units. The device in the center is the most commonly utilized within healthcare, and that's called the Sphere. This unit is designed to either stand on its own or be permanently mounted to the wall, covering smaller enclosed areas like patient rooms. And then lastly, the Sentry XL is the device on the right. While this device is primarily designed for industrial applications, it has found several niches within the larger open areas within healthcare, such as waiting rooms, nurses' stations, or open bed emergency departments. Additionally, these devices are able to overcome the challenges associated with high levels of air exchanges, such as those found in operating rooms and compounding pharmacies. And then on this next slide, you can see that using combinations of these device types, the Synexis engineering team can collaborate with your facilities department to design a deployment strategy that is specifically tailored to the needs of your facility. When properly deployed, a network of continuously operating Synexis dry hydrogen peroxide devices effectively functions as an immune system for a building, as any biological contamination that is introduced will immediately come into contact with DHP molecules in the air, potentially preventing the spread of dangerous pathogens throughout your facility. Next, I'm going to dive into some of the peer-reviewed literature that quantifies DHP's impact on microbial load, as well as subsequent observed impacts on hospital-acquired infections within two separate facilities. The statements on this particular slide come from the first study that I will share with you shortly, where a retrospective analysis in Pediatric Oncology Hospital observed that patients in rooms where DHP was deployed had a 61.4% reduced odds of contracting an HAI during their stay compared to the patients that were in rooms where DHP was not deployed. And so on this next slide, I'm going to dive deeper into the study and kind of give the whole story surrounding it. So in January of 2020, dry hydrogen peroxide was deployed in the 9-bed pediatric intensive care unit of a pediatric oncology hospital. And that initial study, was published about the observed microbial reductions in this pediatric ICU that were observed in the months after the installation of DHP. The study team, however, wished to further analyze the potential impact of DHP on the incidence of HAIs within the facility. So the initial scope of the study sought to simply compare the incidence of HAIs within the pediatric ICU during 2020 compared to previous years. But as we all know, unfortunately, the COVID-19 pandemic really introduced a unique confounding variable into the equation. So to standardize the impact of COVID response measures such as social distancing, masking, and reduced visitation on HAI incidents, the scope of the study was expanded to include the adjacent intermediate care unit, also referred as the step-down unit or the IMCU. So for context, the step-down did not have DHP installed at any point during the study period, serving more as a control, but it did share all healthcare and EVS personnel. Additionally, all cleaning protocols and COVID response guidelines were identical between the two units. And so the study team used a multivariate regression analysis to control for other potential covariates that could impact HAI incidence. And that included everything from patient age and sex to their length of stay, all the way to their cancer type and then the overall prognosis. And then as you can see in the graph on the right, a statistically significant decrease was observed in general HAI incidence within the pediatric ICU from 2019 prior to DHP's deployment to 2020 after DHP was deployed. And while these results by themselves might indicate that COVID response measures contributed to some of that decrease, there was no subsequent change in the intermediate care unit where DHP was not deployed over the same period of time, as you can see in the bottom right. So given the relatively small facility size and the low baseline incidence of individual HAI types, C. diff-associated gastroenteritis was the only specific HAI with a high enough baseline incidence for a subset analysis. But subsequently, a statistically significant decrease in the incidence of C. diff-associated HAIs were observed in the patient population that stayed in rooms where DHP was deployed. And then while controlling for the previously mentioned covariates, the odds ratio generated by the multivariate regression model indicated that patients who stayed in rooms where DHP was deployed had a 61.4% reduced odds of contracting an HAI during their stay. So on this next slide, I'm going to dive into a similar story that was observed in a neurobehavioral unit of a long-term care facility in Rochester, New York. So similar to the study team at the pediatric oncology facility, the study team at this facility published an initial study quantifying the reductions in environmental microbial load after really the deployment of DHP. During their initial investigation, 264 surface samples were collected, half of which were prior to the installation of the DHP. A wide range of surfaces were sampled within the patient rooms and the common areas, and that include everything from dressers to doors to safety gates, among other medium to high touch surfaces. So the graph on the right portion of the slide depicts the average number of colony forming units that were yielded by these samples during the different time points, with days -1, 2, and 3 indicating the time points conducted prior to the DHP activation. And then as you can see on that graph, the microbial load within these continuously occupied areas dropped substantially after the installation of DHP, as a steady state reduction approaching about 90% was achieved and then maintained over the course of the study. Since this facility had no detectable consistent presence of airborne microbial load, just for reference for some of the more technical minded people in the room, the baseline averages were less than 10 colony forming units for the airborne contaminants. So instead, volatile organic compounds were utilized as an indicator metric to simultaneously quantify DHP's impact in the air over the same period. And then for those of you who are not familiar, volatile organic compounds, also referred to as VOCs, are a wide class of chemical compounds that include many strong odor molecules, smells, such as those evolved by construction materials, paint, electronics, as well as things like, that are more common in the long-term care units like C. diff and urine odors. Over the same period, the decrease in VOCs mirrored the decrease in the surface microbial reduction, with a 98.6% reduction in VOCs occurring before the end of the study. And then, but to further continue the story with this facility, unfortunately, patient populations, on the next slide, please. Unfortunately, the patient populations of many neurobehavioral and memory care units are particularly vulnerable to respiratory virus outbreaks, just like COVID. So, since it's really extremely difficult to enforce or to maintain response protocols like masking or social distancing with some of these patient populations. In June of 2024, 3 members of the facility staff developed symptoms of COVID on a Monday and subsequently then tested positive. All 3 of these individuals, 2 of whom were members of the nursing staff, and then one was a member of the kitchen staff, they had all recently worked a double shift on the previous Saturday, just 2 days prior. All 3 individuals had also come into direct contact with each patient in both the memory care unit where DHP was installed, as well as an adjacent long-term care unit where DHP had not yet been deployed. As a result, the facility initiated COVID surveillance protocols, regularly testing all patients within both units. In the long-term care unit labeled A unit on that table that you see on the right, 2/3 of the patient population contracted COVID during the outbreak that then occurred after the exposure over the following weeks. Conversely, there was 0 subsequent transmission of COVID within the memory care unit where DHP had already been deployed. And then later that summer, a second similar exposure event occurred in a ventilation unit where DHP had already also been deployed. Despite 2 patients contracting COVID shortly after exposure, there was no subsequent transmission within the unit. The final series of events that I'm going to share with you today might be familiar to any who have participated in previous webinars. Next slide, please. But given growing concerns surrounding Candida auris, it's important that we share the story around HCA Corporate's initial evaluation of DHP, as well as the subsequent investigations of DHP's ability to impact Candida auris within their facilities. So the first study, as you can see on this slide, the first study investigating DHP's impact on environmental contamination within an HCA facility yielded very similar results to the other two stories that I've shared up to this point. Microbial reductions were observed across the board, but a particularly interesting finding was that DHP impacted the soft textile surfaces of privacy curtains even more quickly than what was observed on the other surfaces included in the study. And then the working hypothesis after the publication of the study is that the polarity of the bacterial cell wall is attracted to the perpetual static charge that's present on these curtains. Similarly, DHP's polar nature would also be attracted to these curtains, which then allows for DHP to impact these highly contaminated surfaces very, very quickly. On this next slide, we'll dive a little bit more into Candida auris specifically. So as concerns surrounding Candida auris really began to grow, HCA corporate decided to investigate DHP's impact on C. auris within occupied patient rooms containing patients who had already screened positive for the yeast. The text on the left of the slide details the initial investigation that it really centered around PCR sampling. And then for those of you who aren't familiar, PCR just detects whether the specific genetic material, in this case of Candida auris, was present on a particular surface. Of the surfaces sampled during the baseline portion of the study prior to DHP installation in these active patient rooms, 70% of those surfaces tested positive for the presence of Candida auris. After DHP installation within these rooms, that proportion was reduced to 17% within the subsequent 7 days. Subsequently, HCA wanted to better quantify this impact, and so they decided to do a second investigation using colony-forming unit sampling at a separate facility across the country where C. auris patients occupied rooms in a burn unit. As you can see in the graph on the right, statistically significant reductions were observed, with the presence of Candida auris being reduced by approximately 90% through those first 7 days, which was then maintained throughout the following week. While this is not yet directly tied to a quantified reduction in HAI Candida auris transmission, it does highlight once again the breadth of the pathogens against which DHP has demonstrated a significant impact in clinical settings. Next slide, please. So in summary, dry hydrogen peroxide has been demonstrated to be an effective tool that, when used as intended, has the potential to reduce the microbial load in clinical environments to the point where it can impact the incidence of certain hospital-acquired infections. By operating 24/7, 365, DHP is a passive source of continuous microbial reduction that can uniquely bolster your infection prevention efforts without the need to hire any additional full-time employees to impact that deployment. So please, once again, contact the Synexis clinical team to learn more about how DHP could be utilized within your facility to combat these dangerous pathogens that contribute to hospital-acquired infections. I will now hand it back over to Dr. Ramos for some final insights. Thank you.
Thanks, Chris. Great summation of some wonderful articles and research. So we start talking about ROIs in how do we create an ROI for what we do? And really, I think you're looking at prevention, and I'm not going to read the whole slide to you, but preventing one hospital onset C. diff avoids estimated costs equal to the price of 75 Sphere devices. So that's significant. But I want to pivot a little bit to talk a little bit about systemness. Every system is perfectly designed to get the results it gets. If you're not where you want to be, you need to change the process. The culture of your facility will eat strategy for breakfast every day. So get people on your team that have the same values of preventing HAIs. And this doesn't necessarily need to be an infectious disease physician. If a cardiac anesthesiologist has a goal and desire to help out with reducing HAIs, get them on your team. Team up with your EVS, your CMO, your ID physicians, your pharmacy, anybody, nursing leadership, your CNO, CFO, anybody who you can get on your team that wants to help prevent HAIs is important to get them on your team and working and set high goals for yourselves. There's a reason people are able to achieve 1,000-day reductions or 1,000 days without a CODI or a CLABSI. They've changed the way they've done. They're doing business. They've got the right people on their place, and they put a process in place, a standardized process in place that is consistent throughout the organization. that's how they're able to achieve that. So thank you all again for joining us. I'm going to turn it over to Dave because, as Chris mentioned, reach out to your Synexis folks to help you out with a business plan of how to present that to your C-suite. And I want to thank you all for your time today. David?
Thank you so much, Dr. Ramos. We do have a few pre-submitted questions. One of our attendees asked, we do have UV in our facility. Will DHP work with UVC?
Thank you, David. I can field that one. So the short answer is yes. Dry hydrogen peroxide and UVC machines are extremely different technologies with different intended applications, but this does allow them to work well together in synergy. So for instance, whole room UVC disinfection is an example of an intermittent cleaning technology, often used in terminal cleaning practices. But when it's deployed properly, it can really do a great job of effectively resetting the microbial load within a space to effectively zero. The only downside is that it really can't be utilized continuously within occupied spaces. So when DHP is deployed within a space that utilizes UVC or other intermittent disinfection technologies, DHP works in the background and it addresses new sources of contamination at the point of introduction to the environment. As a result, DHP is really able to mitigate those spikes in microbial load that occur in between the intermittent cycles of usage of things like UVC, potentially keeping those spikes in check until the next deployment of intermittent manual or terminal cleaning practices.
Thank you. Another question was, how is DHP different from other technologies such as vaporized hydrogen peroxide or bipolar ionization?
That's a great question. So first, I will address the differences between dry hydrogen peroxide and the aqueous forms of hydrogen peroxide, which include things like vaporized hydrogen peroxide. So vaporized and aerosolized forms of hydrogen peroxide use a liquid solution that is then disseminated into the air. These aqueous forms of hydrogen peroxide are very highly concentrated, so they cannot be deployed either continuously or in occupied spaces. Additional precautions also typically need to be taken, so such as things like covering the vents and the doorways, as well as covering any electronics or other sensitive materials that are susceptible to corrosion due to aqueous hydrogen peroxide's acidic chemistry. Dry hydrogen peroxide, on the other hand, is not produced from an aqueous solution. It's instead produced from the ambient humidity and oxygen that's already within the air within the space. So DHP is the true gas form of hydrogen peroxide with absolutely no moisture or water molecules bonded to the individual molecules of DHP, thereby eliminating any risk of corrosion. Lastly, DHP is produced at extremely low concentrations, roughly 2 parts per billion with a B, which is roughly 1/500th of the permissible exposure limits for hydrogen peroxide published by OSHA, NIOSH, and ACGIH. You also mentioned bipolar ionization. So bipolar ionization, on the other hand, that utilizes pairs of oppositely charged electrodes that provide energy needed to break down humidity and oxygen into a mixture of oppositely charged ions and free radicals, often referred to collectively as plasma. So existing literature indicates that once this mixture of ions and radicals leaves the device, they recombine back into humidity and oxygen within a few feet of travel. So as a result, bipolar ionization has really been the most successfully utilized as a supplement to air filtration devices, either within the HVAC or in standalone units. But the thing is, they have to wait for airborne microbes to pass through the device in order to neutralize them. Synexis devices, on the other hand, since they produce DHP, which is in itself a stable, uncharged molecule, it can travel longer distances and impact microbes on both the air and on surfaces within larger spaces.
Thank you. One more. Do DHP devices produce any ozone at all?
Great question. So no, DHP devices create zero ozone. So all Synexis devices have UL 2998 certification, which means absolutely zero ozone is produced by the devices. I'd also like to take the opportunity right now to point out that there are actually 2 ozone-free certifications that a device can obtain from Underwriter's Laboratory, and those are UL 867 and UL 2998. So while UL 867 allows for a device to produce up to 50 parts per billion ppb of ozone, UL 2998 is far more stringent, and it's only awarded to devices that produce absolutely zero ozone during the entirety of the testing period. As I mentioned earlier, all Synexis devices are UL 2998 certified.
Thank you so much for those great answers, and I really appreciate everybody joining us today. And another thank you to Dr. Ramos and Mr. Lee for their excellent presentation regarding HAIs, the value of no-touch technology, and Synexis's patented DHP technology. I hope this has been as enlightening for you as it was for all of us. Just one reminder, there will be a survey that comes up as soon as I end this webinar. So I encourage you to provide your honest answers so that you can help us get better at this. Plus, filling out the survey and scheduling a short meeting to learn more about Synexis gets you an entry into a drawing for a free sphere. So make sure you take that survey. Thanks again, everyone, and I hope you have a great day.